Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. So let me start with today's first lecture, which is about Gerd, very commonly tested in licensing exam, whether you're doing the MCQ one or NAC OSCE. In both exam, it is very high yield. You will definitely get a few questions out of a few questions, probably one, two, or in some cases, in some exam, they prefer to have even more than two. So something that you need to study and put your heart into it before you go to the real exam. Okay. So the core symptoms, the key rule must not miss why it matters for the MCQ1, high yield outcomes, and everything. So by the end of today's lecture, you should be able to diagnose, uh, ma manage the GERD. So in terms of core symptoms, obviously it is heartburn and regurgitation. The key rule is typically the GERD is a clinical diagnosis. So it means we do not need to over-investigate the patient unless there are risk factors present. So must not miss something that we shouldn't be missing is dysphagia, weight loss, and bleeding. Why? Because they are the red flags. And if they are present, it means that we need to go deep and do further investigation, starting with endoscopy. So why it matters for the MCQ1, symptoms pattern recognition, appropriate test selection, PPI-based management, Barrett's and adenocarcinoma risk. So high yield outcome, diagnose common, vignette fast, choose endoscopy when it matters, avoid over testing and complicated case. So it means that mostly it is kind of a common mistake by IMGs that they're jumping into diagnose or invasive diagnostic investigations like endoscopy, even if it is not if it is uncomplicated or not complicated case of GERD. So if you do not have the red flags, so I think we should just uh, rely on the clinical findings, and based on that, we can put our diagnosis. Right. So recognize, how do we recognize the GERD? Obviously, the heartburn, regurgitation, and it's very typical. Extra esophageal symptoms, which we are going to discuss it later on. They are kind of helping us or supporting the diagnose, but they are not required for the diagnose, but they can support. So decide clinical diagnose if typical alarming features. The alarming features could be stricture, Barrett's, adenocarcinoma, or as I mentioned before in the previous slide, it could be dysphagia, weight loss, and bleeding. So these are the alarming features. Treat PPI. The question you might get, they might give you a scenario about somebody who is suffering from GERD, and they might ask you what is the most effective therapy for this patient. The most effective therapy is always PPI. Lifestyle adjunct still matters. It means that the lifestyle therapy or lifestyle changes or modification could be part of the treatment, but they are not considered as only treatment or the sole treatment for the GERD. So the PPI is the most effective. Investigation, do we have to do it? And yes, we do. But when we have alarming features or when there's risk factor present, otherwise we don't have to even do the endoscopy. So let's say endoscopy, if the patient has alarming feature or refractory, the pH test, remember I made it bold and I made it red. If you're getting a question that the patient has GERD and the patient is not responding to PPI, or the patient has risk factor. Now you are moving on to the next step because the clinical diagnosis now not enough, so you have to dive deep into investigation. So if you're not able to go ahead and put your diagnosis based on the clinical diagnosis, so the next step should be the endoscopy. Now let's say the endoscopy is inconclusive. If the endoscopy is inconclusive, what is the next step? The next step should be the pH test, which is the most accurate test for the reflux. Remember, if you are given a picture or a scenario and they're asking you about the most accurate test for reflux, your answer will be the pH test. So preventive structure to prevent, basically the treatment we do or provide is to prevent from the condition like Strich, Barrett's, and adenocarcinoma. The typical symptoms, as I mentioned before, heartburn, regurgitation, no red flag. So if there is alarming features like dysphagia, weight loss, bleeding, vomiting, we need to do endoscopy, manometry, and 24 hours monitoring. So again, endoscopy comes first after a clinical diagnosis, and then manometry if you're suspecting a problem with the motility or peristaltic movement. In that case, you can do that. And 24, if you are asked about the most accurate test for reflux. So the long-term risk could be, or the complication could be stricture, Barrett's esophagitis, and adenocarcinoma that we are trying to prevent these long-term complications by proper treatment. So in terms of pathophysiology, inappropriate transit, lower esophageal sphincter relaxation, which causes the GERD, mechanical and motility, delayed esophagus clearance, delayed gastric empty. In that case, you can do the manometry as well. Reduced barrier tone. This might be in the licensing exam, somebody with a scleroderma. What would be the mechanism? It will be the low basal, lower esophageal sphincter tone. And also amplifier could be obesity. So if the amplifier the obesity, so the treatment could be weight loss. Pregnancy, we have to wait until the deliveries happen. Rare acid hypersecretion. So hiatal hernia, remember hiatal hernia worsens the reflux, but it does not directly cause the GERD itself. So it means if you have a hiatal hernia, it could just worsen the GERD that you have. It by itself does not cause the GERD. That might be one of the question in the licensing exam, MCCQE1. So typical esophageal, I think we already talked about this. So other esophageal symptoms that might be present, water brush, global sensation, frequent belching, and chest pain. Late or less common could be dysphagia and rare odonophagia, and these are also alarming features. Extraesophageal. Extraesophageal symptom could be chronic cough, hoarseness, wheezing, dental erosion. Sometimes they might mention these symptoms in the scenario, and you should be able to tell if this patient has GERD or the patient has another issue. For example, they might come with a chief complaint of chest pain, and the patient has chronic cough, hoarseness, wheezing, dental erosion. And at the same time, the patient is using PPI on and off, not on, he's not compliant with the medication. So you need to rule out the GERD. So the key MCCQ1 interpretation, heartburn, plastic regurgitation strongly suggests GERD. It means if you have heartburn plus regurgitation, it is equal to GERD. That is called clinical diagnosis. So you don't need to over-investigate the patient unless your patient has alarming sign and symptom. Then you can escalate. Then you can do further investigation. Extraesophageal symptoms, for example, if the patient on top of heartburn and regurgitation has chronic cough, hoarseness, wheezing, dental erosion. They are poor predictor by itself and should not by themselves put the diagnosis. It means if they are present, they support the diagnosis. But if they are not present, they cannot rule out the diagnosis. They can just support, but if they are absent, it doesn't mean that GERD is not the diagnosis. Dysphagia is a red flag when progressive or associated with weight loss. Clinical diagnosis first, but not always. So typical symptoms, again, we already mentioned it. Diagnose approach, usually a clinical empiric therapy reasonable. A PPI response support the GERD, but it's not required to make the diagnosis. So we have heartburn plus regurgitation. It's equal to GERD. And also, if you want to support the diagnosis, you can also mention that the patient has tried the PPI and got better. So it means the patient using PPI getting better is not required for diagnosis, but it can support the diagnosis that you already have. Okay. So alarming feature, as I mentioned before, dysphagia, weight loss, bleeding, persistent vomiting, family history of cancer. These are the things. If you have it, now you can escalate. So we never over-investigate the patient who has GERD but not complicated, or GERD without any alarming feature. But GERD with alarming feature, now we have to do the endoscopy. Do not over-test uncomplicated reflux, as I mentioned. Typical symptoms, no red flag, no immediate endoscopy is needed. So do not jump right away to endoscopy. Reserve testing for alarming feature, refractory symptoms, or complications. We only do it if we have complication or alarming symptoms, or if the patient is not improving despite using PPI. Now, endoscopy triggers and Barrett's risk. So immediate endoscopy triggers could be these alarming symptoms, which I'm not going to go through them all one by one because I have mentioned it so many times. Refractory symptoms could be persistent reflux despite an adequate optimized PPI trial. You prescribe the patient with a proper dose and course of PPI, but still the patient is having reflux. Now I can do the endoscopy to see if I have the right diagnosis. Severe erosive disease after treatment. You know, we have erosive and non-erosive. If it is non-erosive, we are treating as needed with PPI. But if it is erosive, the patient will be on PPI indefinitely. But if the patient on PPI is not improving, now I can go ahead and do the endoscopy. So Barrett risk factor could be the male. These are the things that we have to remember. If they want to give you a picture, a scenario about the Barrett's, it will be usually a male, usually above 50, usually with obesity, usually a white in terms of ethnicity, tobacco user or a smoker, long symptoms, duration of GERD. These are going to be present as a clue in the scenario. For example, let's say Ahmad, 55 years of age, and let's say he is 300 pounds, white Caucasian, and also he has been suffering from GERD for almost 6 or 10 years. Now I know that I'm dealing with Bird's disease. Severe esophagitis often needs repeat endoscopy after PPI therapy because inflammation can mask Barrett's esophagitis. Test compare what each one actually tells you. So gastroscopy or endoscopy. Best when alarm feature or complication are suspected, shows esophagitis, ulcer, stricture, and Barrett's. Can be normal and non-erosive disease, not the most accurate. Remember, the most accurate is the pH. This is used as a first investigation in refractory or any GERD with alarming features. but it is not the most accurate for the reflux. For the reflux, the most accurate will be the pH test. Now, manometry assess motility and lower esophageal function, useful with the chest pain, dysphagia, and normal endoscopy required before fundoplication. This is the key. Usually, if they want to test you on this, they usually give you scenario about someone that who is having GERD for a very long time, and he has done the endoscopy. Endoscopy is normal, and the patient is getting worse, or the patient has abnormal and the patient is to the point that not responding to the PPI. Now the patient requires surgery. Now, before doing the surgery, I have to do the manometry. Okay, does not diagnose reflux directly. Reflux, think about pH. If they are asking you about the most accurate test for the reflux, think about the pH. 24-hour pH monitoring, most accurate objective test for reflux. This is very commonly tested. I would encourage you guys to memorize this. Best when symptom persists despite the therapy or the diagnosis uncertain. For example, you do done endoscopy and the endoscopy result is inconclusive. So they might ask you in two different ways. Let's say, first scenario, they give you a picture of somebody with a GERD, and now they ask you that the patient is not improving with PPI, and the patient is have done the endoscopy and the result is inconclusive. What is the next step? What is the next step? If you have GERD, endoscopy inconclusive, my next step is to do the pH. Or in a different scenario, they might ask you, for example, you have a patient with all characteristic of GERD. They're asking you specific, what is the most accurate test for reflux? That would be the pH. Not required and most typical. And something that you need to know that we don't normally do this on routine investigation, like on daily basis. We don't do it. That's only when it is required. That's only when the patient is getting worse, but the endoscopy is not helping you to come up with the right diagnosis. Now you have no other choice to go ahead and do the pH. So example, most common approach, clinical diagnosis. So again, what is the diagnosis of GERD? Mostly clinical. Most accurate test, if they're asking you about the reflex, most accurate test is the pH. The treatment. So lifestyle is obviously the first step. Lifestyle changes or modification. So they might ask you the most effective, remember, the most effective lifestyle change or modification. It will be weight loss and head of bed elevation. These two. If they're asking you about the most effective non-pharmacological treatment, the most effective non-pharmacological treatment, or the most effective lifestyle modification that helps with the GERD, weight loss and head bed elevation. If they're asking you what is the most effective treatment, it is PPI. Or what's the most effective pharmacological treatment, it is PPI. Antacid, H2 blocker, PPI as needed for the non-erosive, but we use it for erosive indefinitely. Most effective, again, if they're asking you for the most effective pharmacological treatment, it will be PPI, the first line and most effective. Best for the symptom control and healing. Maintenance. Again, we don't usually use the maintenance unless it is erosive. In that case, we have to use the PPI as a maintenance. Surgery is used selectively if it is not improving with the medication and with the optimized pharmacological treatment. It means you choose the PPI, you optimize it, you increase the dose, but with a maximum tolerated dose, the patient is not improving. Now we have no other choice but to do a surgery. But before we do surgery, what do we do? Manometry. Use manometry first. Dietary triggers may worsen symptoms, but they do not change the underlying disease mechanism. So they could be part of the treatment. Now, in terms of non-erosive and erosive esophagitis. For non-erosive reflux disease, normal esophagus on endoscopy. Aim is to relieve symptoms. And reasonable approach on demand antacid, allogeneic H2 blocker, and PPI. But now, esophagitis, or if it is erosive, endoscopy will have endoscopic esophageal inflammation. So in this case, the aim is to heal the mucus and prevent recurrence. For this one, often requires maintenance or indefinite PPI. This might be a question in the licensing exam. Remember, if it is non-erosive, you can use PPI as per needed, okay? Non-erosive, as needed PPI. Erosive, indefinitely, okay? Fundoplication in selected patient. Now, complication you must recognize early: esophagitis, ulcer, bleeding, stricture, Barrett's, and adenocarcinoma. So for the stricture, progressive, remember, they might test you on this one as well. We will do this in details while we are doing dysphagia. But for the stricture, usually they will give you a scenario about someone who is progressively getting worse while he's eating solid food. For example, bread, meat, and stuff like that. So it's progressively getting worse. If that is the case, then think about a stricture. Think scarring from the chronic reflux injury. Now, Barrett's clue, if they want to test you on that, again, there will be certain clues. For example, for Barrett, they will mention a male patient, over 50, overweight, white ethnicity, and long-term Gerd. That is the key. Out of all of them, remember, long-term reflux or Gerd. That is the clue for the Barrett's disease. And Barrett's, why it is very important, because it's a pre-malignant metaplasia of the cancer. It means the next step after the Barrett's would be cancer. So it starts with stricture. So obviously esophagitis, then ulcer, then stricture, then Barrett's, then adenocarcinoma. So the big one is stricture, Barrett's, and cancer. So Barrett increased risk of esophageal adenocarcinoma. Just remember, it is not a squamous carcinoma, usually very commonly mistaken by IMG that they go after squamous adenocarcinoma. It is not a squamous, it is esophageal adenocarcinoma, okay? So this might be also in the licensing exam, one of the options. That's why I made it red and bold. Endoscopy matters in the red patient. Esophageal adenocarcinoma. For the counseling, for those of you who are attending the NACOSCI, so this would be very important to remember on top of other stuff that you need to do for the counseling station. So why PPI matters? Most effective medical therapy for the Gerd, heal erosive esophagitis, often needed long-term when the disease is erosive or complicated, which I mentioned indefinitely. Clear indication still justify chronic use. Now, counseling period, stopping abruptly. These are the things that we need to counsel the patient and educate the patient that why we are providing you with the PPI and how often can you use it. Why is it important to be a compliance with your medication? What happens if you stop it abruptly? And one of the things that they require you to know to do it while you're doing the consultation or counseling station for the patient, that you need to mention that you shouldn't be stopping the medication without any healthcare advice abruptly. Why? Because it could cause a rebound acid hypersecretion. And use the lowest effective strategy once stable, no reported long-term association, but do not overinterpret them. MCQ per, the right message is not avoid PPI, but use them deliberately when the indication is clear. Now for the vignettes algorithm, symptoms, just to summarize everything, what is the most common symptoms that we have is heartburn, plus regurgitation is equal to Gerd. Now, the red flags that we have to look for is dysphagia, weight loss, bleeding, vomiting, uh, all this. If we have it, it means we should not um, just go based on the clinical diagnosis. We have to escalate. We have to do endoscopy. Now, choose the pathway, the clinical diagnosis. If typical endoscopy, if alarming feature is positive. Now, how should I treat the patient? Now, the first line of treatment, if it is asking me about the pharmacological treatment, will be PPI. If it is asking me what is the first best choice non-pharmacological treatment, I would say weight loss and heart beat elevation. Okay, so pay attention to the pharmacological, non-pharmacological best choice. If symptom persists despite appropriate therapy, recheck adherence of the patient to the medication and optimize PPI timing and dose. It means, let's say they give you a scenario about someone that who has Gerd, but he is not improving. So what would be the first best approach? Should I increase the dose? Should I do endoscopy? Should I do the pH test? Should I do the monitoring? The first thing that I need to do is to make sure that my patient is taking the medication. I have to ask him, are you taking your medication on daily basis as you're prescribed? And the patient says, you know what, sometimes I forget it. So it means that the treatment is right. Just we have to counsel the patient to know the importance of being adherent to the treatment. That's it. Just educate the patient how important it is to be adherent to the treatment. Take the medication on right time. Do not miss it. Let's say the patient is adherent and compliant to medication. Now, if I'm using something like, which is a lower dose, before I start to escalate things, how about if I increase the dose? That would be the smart move. So let's increase the dose before starting doing endoscopy. Now, if I am using, then my patient is adherent to medication and I'm using the maximum tolerated dose of the PPI, and I have combined it with H2 blocker 2, so the patient is not improving. Now I have no other option but to escalate it. Now I'm doing the endoscopy. Endoscopy if the alarming features are present or if the patient is not responding to optimize treatment. Now consider pH 24-hour pH monitoring if the diagnosis remains uncertain. Again, I'm just trying to explain it again so that you know when you have to go for the right investigation. We never go for the pH as an initial investigation unless it is asked specifically the most accurate test for the reflex. Then I can go for it. But if it is asking me what is the next step, the patient is adherent, the patient has already taken optimized or high dose of PPI, the next step is not pH, it is endoscopy. But if endoscopy doesn't help me, the next step is the pH. Now, if let's say none of them are helping and the patient is getting worse, and now the patient requires surgery, before doing the surgery or fundoplication, I need to do the manometry. Okay? Example you should leave with. So these are the things that we have discussed, so I just summarized it in one slide. Heartburn plus regurgitation strongly suggests GERD. Typical GERD is usually clinical diagnosed. Transit lower esophageal sphincter relaxation is the most common mechanism. Remember, that might be in the exam. Hiatal hernia can worsen the GERD, but it is not the cause by its own. PPI is the most effective medical therapy. It is not the non-pharmacological, it is the pharmacological most effective therapy. If they're asking you what is the most effective non-pharmacological treatment, it will be weight loss and heartbeat elevation. So pay attention to the wording. Dysphagia and weight loss, not only dysphagia, weight loss, if the patient is having some sort of, like, for example, nausea, vomiting, and the patient has fever, and the patient has all sort of other condition that raises eyebrow. Now, in that case, I have to do and escalate the investigation. 24-hour most accurate test. Remember, this is the most accurate test for reflex. Just to be very specific, for reflex. Manometer assessment mortality, not reflex. Progressive solid dysphagia suggests a structure. Progressive solid dysphagia. We will discuss this when we are discussing the dysphagia. But for now, just remember this much. Progressive solid dysphagia suggests structure. Chronic GERD can progress to Barrett's, and Barrett's progress to adenocarcinoma. Thank you very much. Let's do a few cases.